Are you ready to be connected? You're listening to the Insured Connection podcast by Pica Group, a pro assurance company, where we provide expert advice for your practice when you need it most. We connect you with industry leaders to discuss timely topics so you can listen, learn, and get back to caring for your patients. Now, let's connect.
Welcome to the Insured Connection podcast. I'm your host and PICA Medical Advisory Committee member, Dr. Katie Swanstrom. In honor of Skin Cancer Awareness Month, today we're focusing on a diagnosis that can hide in plain sight. I'm joined by Dr. Bill Scherer of Bako Diagnostics, and together we'll discuss why podiatrists are a critical frontline physician in spotting suspicious lesions on the foot and leg. We'll also cover foot-specific warning signs to watch out for, documentation and referral considerations that can reduce your malpractice risk, and practical ways to educate your patients during routine visits. I'd like to begin by having Dr. Scherer introduce yourself.
Hi, I'm Dr. Bill Scherer. I'm in South Florida, Delray Beach, graduated Barry University, and I'm a clinical consultant for Bako Diagnostics. And basically, I've been a podiatrist a long time and a PICA member for my whole career, and looking forward to today's session.
Great. As am I. Well, we'll jump right in. So the CDC, in their most recent documentation or reporting of 2022, lists the incidence of melanoma as 23.8 per 100,000 in the population of the United States. But their messaging to the public is mostly around sun protection. And the feet are not high sun exposure areas, but can get skin cancer. So why should podiatrists be especially vigilant?
Number one, it's not just melanoma. A melanoma is the most deadly form of skin cancer, but really we need to be looking at all three of the most common ones, which is squamous cell carcinoma, basal cell carcinoma, malignant melanoma, and then even the really, really unusual ones, like even Merkel cell. I mean, sure, a lot of those don't affect the lower extremity, but I think most of the messaging is probably from dermatology, which the majority of skin cancer is found in the upper extremity areas. The majority are found on Caucasians or light-skinned individuals, and the majority of skin cancer are found by dermatologists or even PAs. So it's not necessarily, I think, that they're forgetting about the lower extremity podiatry. I just think maybe we're not high on their radar. And really, another thing that I think most podiatrists don't realize is that skin cancer is really quite common in the lower extremity. This is not unusual. A lot of podiatrists maybe go their whole career without diagnosing skin cancer, which I find is really, really unusual when there's a few podiatrists, a handful of podiatrists in the country, seeing 20 or 30 skin cancers every year, which is amazing to me. Skin cancer is the number one most common form of cancer total body, represents about 40% of all skin cancers total, and it's going to affect the lower extremity, maybe not as much as the head or neck, but certainly, or the upper torso, but it definitely exists, and it's a significant condition. It's probably one of three conditions that we see as a podiatrist can actually kill your patient. So I certainly think that warrants a better understanding and really better education. I think what happens when you look at our schools, maybe we have one or two courses in dermatology where you're probably going to get 5 or 7 in surgery. In residency, you're doing a 3-year surgical residency, and maybe you do a week or two in so I think it's really just not ingrained in the curriculum of podiatry, where we've kind of really gravitated towards musculoskeletal. I think it's really time to reset that bar and bring it back to dermatology and improve our education, improve our residencies, improve our rotations, because basically dermatology, skin and nail conditions represent probably over 50% of the patient encounters that we have as an average podiatrist. So it's a very important topic.
That is true. Yeah, and we also see our patients more frequently oftentimes than patients see a dermatologist or even their PCP. So those are good points. So what are some cases that you've encountered where skin cancer has masqueraded as a common foot problem?
Well, I would probably say the number one is probably looking at what we would think is a squamous cell carcinoma, where basically it masquerades as what maybe think is a plantar verruca. That would probably be number one. So I always kind of warn podiatrists that, if you see what it looks like a plantar wart or just any wart that looks kind of like a really aggressive looking one or one that looks unusual, a lot of times if that's been there a long time in an older population, I'm not talking like a teenager that just comes in with a plantar wart. I'm talking a lot of times those are squamous cell carcinomas. In a non-healing chronic ulcer or wound, sometimes those are either a basal cell or squamous cell carcinomas upon biopsy. And every once in a while, we find an amelanotic melanoma, which probably is the scariest one of all, in my opinion, because it looks just like a standard ulcer and it lacks all the pigment changes of a malignant melanoma, so it doesn't look scary. The problem is that there's always a significant delay of diagnosis and a delay of treatment, and then those patients have a high metastasis rate. So by the time the diagnosis is made, it's much more difficult to treat. So those are kind of the ones that I think are most common. In the nail or nail plate, we'll kind of see acral lentiginous malignant melanoma, and that's kind of hard to differentiate between just a linear streaking and a nail. So I would say those are the most common ones that we see as a profession.
And how long do you typically allow a lesion to be there before you'll consider biopsying it?
Well, that's kind of a magical question. I think the older I get, my answer is going to change to more aggressive and sooner. So maybe in the past when I was younger, I think the attitude for a lot of us is, well, this lesion is not hurting you. It's not scary looking, or maybe it doesn't bother you too much. And well, let's monitor it, or we'll see in a few months to see if it changes. And quite honestly, the older I get, the more I realize that no, we need to really biopsy these sooner than later. If you see a lesion, whether it's a pre-existing nevi, if it's a lesion that has changed in size, shape, color, elevation, a lesion that begins to itch more, slight bleeding, all of these are kind of warning signs that maybe that is a cancerous lesion. And an ulcer, as great as podiatrists are at treating ulcers, a non-healing ulcer over a period of time, assuming you've ruled out osteomyelitis, peripheral vascular disease, all the other common things, it could be a malignancy, because a malignancy, whether it is a amelanotic melanoma or a squamous cell or a basal cell, none of these are going to respond to conservative treatments. That is kind of another warning sign, is if you have a condition that's not responding to conservative treatment, then again, I think to answer your question specifically, I'm doing biopsies on the first visit. That's not unusual. Where in the past, I probably would monitor it, or let's see how it goes down the line, mainly because in our education, we've been trained so much on musculoskeletal and orthopedic that I think when a podiatrist does a rotation with dermatology, or they spend time looking at reading the journals or going to some of the CME lectures on dermatology, then you really have an epiphany where you have this revelation like, oh my God, how many of these have I missed in my career? And I'm not ashamed or embarrassed to say that I'm sure there are quite a few skin cancers that I've missed in my career. Now, I'm reasonably certain that that's going to either be a squamous cell or basal cell. I don't think I missed any malignant melanoma, but an amelanotic melanoma I may have missed. I mean, we don't know unless you do biopsies. And sometimes we're treating an elderly population that may see a lot of other doctors, and maybe we don't always get the full picture on patients. So to answer your question, sooner is always better. The nice thing about skin cancer is that the earlier you diagnose it, the more aggressive you treat it, the better your outcomes are going to be. So we as a podiatrist, we can actually be the hero. We can save somebody's life. We can technically cure cancer. I'm not saying we're curing cancer, but we've cured the condition by excising it and taking appropriate skin margins. In theory, you've treated it, and the patient will live if it hasn't metastasized. And the number one thing is catching it early and not delaying your treatment. And that probably will lead to your best outcomes.
Yeah, I completely agree. I mean, these patients will come back and tell everyone that they see in your waiting room that the doctor saved my life.
Yes.
And it's so
That's a
rewarding.
good feeling, right?
We don't get that very often as foot
Yes.
and ankle specialists.
Again, they call it a chief complaint for a reason. So we've established that every patient comes in your office, a new patient, they're complaining about something. So our job is to kind of help them alleviate these situations.
Yes, agreed. So when you see a suspicious lesion, what are the important things to document? Whether you're doing a biopsy day one or first visit, or you're going to wash it, or you think it's something else initially.
Well, let's start with the most obvious thing. A lot of times you hear about that ABCDE classification of skin cancers or lesions. I'm not going to go through all the ABCDE classification is. I am, believe it or not a big fan of the ABCDE classification, only because I've seen so many exceptions to that rule. I prefer the F word, and I think everybody knows what that is, and that is funny looking. So if you see a lesion that is funny looking or unusual, maybe you're thinking the other F word, but I'm thinking the funny looking one. Basically, if there's a lesion that just looks unusual to you, if you're thinking like, wow, that just doesn't look right, or suspicious, your index of suspicion. That's the reason to do the biopsy. That's the reason to investigate that. And honestly, that's the simplest one of all, is just use your eyes, your senses, and do a thorough history and physical. Every time a patient comes in the office, you should be looking at the entire lower extremity, even if they're coming in for a hammer toe or heel pain or a fungus toenail. You should use that as an opportunity to at least do a thorough examination. It doesn't take that long, and you're being a comprehensive lower extremity expert. We're not just laser focused on the foot, or we're not just laser focused on the chief complaint, bringing the patient to the office. And I think that makes the difference for a lot of physicians in terms of identifying and treating skin cancers.
I agree. So when you have specifically younger physicians who maybe been out like 3 to 5 years, sometimes it can be difficult to kind of talk a patient into allowing the biopsy, especially if it's around the nail or doesn't hurt. So how do you go about that?
Like what you're hearing? Go ahead and subscribe so you never miss an episode again. Now, let's continue to connect on today's topic.
Well, that's a really great question, and a lot of this comes from experience. So, for example, probably the number one misnomer with all skin cancer, and this applies to both physicians and the general public, is the fact that skin cancer is not painful. 99.9% of all skin cancer is not painful. There's a lot of reasons for that. We don't really need to get into that. But if a lesion is not painful, even if it's the small little lesion that has changed in size, shape, or color, a lesion that has jagged edges, that has some itching and presence of bleeding, all the warning signs are there. But when the patient says, well, gee, doc, this doesn't hurt me, why do I want a biopsy for something that doesn't hurt me? Then that becomes our job as physicians to explain to patients that look, number one, the majority of skin cancers are not painful. That is a significant public relations and public health problem, because honestly, if skin cancer was painful, that would be great for everybody, because then it would bring patients into the office for treatment. But our bodies are not designed that way. A skin cancer starts usually in the epidermis. There's not a lot of nerve endings in there. It generally grows slow. There's a replacement of normal cells with malignant cells. And a lot of times, the warning signs are very subtle at first, but certainly I would tell these physicians to really think about approaching dermatology with the same vigor and vitality as they approach musculoskeletal. So, I'm super proud to be a podiatrist. I think the advances we've made in our profession since I've joined podiatry, where we were lucky to do bunions and hammer toes, back when I was in school. The average podiatrist was doing maybe a 1-year residency. There were really almost no 3-year residencies. And today, every single podiatrist is doing 3-year surgical residencies. So our surgical skill is far greater than we've ever been in our entire profession. We've achieved parity, and we've advanced and gone beyond with orthopedic surgeons in terms of treating the lower extremities, specifically foot and ankle. But I really, really think we put dermatology on the back burner as a profession. And I'm not sure why we've done that. It's a huge market opportunity for us. There's tremendous amount of volume of patients for that. There's a need for this. And I think it really boils down to just education. And it's really, maybe it's convincing the APMA or the schools to maybe allocate a little bit more attention to dermatology when so little of this is taught in school and residencies. It's a little frustrating. So to me, I tend to lecture pretty much exclusively on dermatology topics now, and I go around the country. I visit almost every major medical conference, and it really saddens me to think how little lectures are either on skin cancer or onychomycosis or nails in any of the meetings, including the APMA National. And what happens is that a lot of times you're seeing just a few doctors lecturing on dermatology. So I think it would be really, really nice to see some of the younger doctors expressing more of an interest in dermatology, because I think it's a great opportunity. And not everybody needs to be an ankle replacement surgeon. That's as simple as that.
That's true. And a lot of dermatologists don't really even like to see foot problems. They would rather have it be looked at by a podiatrist.
Well, actually, it's interesting that you bring that up. You're right. Most dermatologists, they certainly don't like toenails. That's a given. They don't really like ulcers. They don't like corns and calluses. They don't like lesions on the feet. I mean, some of them will deal with that. Most of the high-end dermatologists are now cosmetic dermatology, and quite honestly, if I was a dermatologist, I'd probably do the same thing. What I am really seeing now is a little troubling is the fact that, you're now having dermatology PAs and foot care nurses that really are growing in numbers because they are meeting the demand for skincare of the lower extremity that a lot of podiatrists don't want to do. "Oh, I don't want to trim toenails. I don't want to deal with corns and calluses. I don't want to deal with skin lesions." They just want to be big surgeons dealing with musculoskeletal. And quite honestly, we're at risk at losing that. I mean, we're risk at losing that to a PA, a dermatology PA that is very, very, very interested in the lower extremities. Nurses are very well versed in nail and foot care. And if we're not careful, they will replace podiatry as being the foot care experts for lower extremity dermatology, at least. And I think that would be a big shame. I don't want to see that happen.
Yeah, and I agree. Like you said, it is about 50% of our patient encounters
Yeah.
nationally. So we don't want to lose that income, for one.
Yeah, and it's big. I mean, you know, honestly, dermatologists and plastic surgeons are probably the top 2 professions now,
Indeed.
so I'm not sure why we don't give it more attention. And I get it. I mean, surgery is glamorous, surgery's fun. Every young doctor in school and residency wants to go home and tell their parents that, "Yeah, I'm a big surgeon. I'm a foot and ankle surgeon. I'm a reconstructive surgeon." That sounds great, but the fact of the matter is surgery really represents a relatively small portion for the average podiatrist. And certainly dermatology is way more common skin and nails than musculoskeletal.
Yes. So going back to the biopsies, when should a podiatrist biopsy themselves in the office versus refer out to a specialist like an oncologist or a dermatologist?
Well, number one, I would like to say we don't need to refer out. That would be number one. In terms of when to do the biopsy, earlier is going to be better. I think what happens is that when you look at doing biopsies, look, it hasn't, as I said, in school, maybe you have one course in dermatology. You might even only have one class, 1 hour on skin cancer, or 1 hour on nail care. In the clinics, maybe they might do a biopsy once or twice in school, and in residency, you in theory could do a 3-year residency without ever doing a biopsy. So what happens is, a lot of times podiatrists, will graduate after 4 years of school and 3 years of residency, and now all of a sudden they're in clinics. They're like, "Oh my God, how do I treat these things? Because I'm only doing fusions of the first metatarsal base, and I can do that real well, or I can replace an ankle. But oh my God, doing a biopsy, that's like a foreign concept to me." So I don't think we need to refer out. Now, the truth of the matter is you do a biopsy and you diagnose malignant melanoma or something really significant like amelanoma, you have to ask yourself the question, do you really want to treat this? So 100% of the podiatrists in the country are well versed and well qualified to do a biopsy to make the diagnosis. You can make the diagnosis of skin cancer. Now, whether you treat it or not is up to you. You may not feel comfortable. Maybe you want to refer it out to a dermatologist or a podiatrist at a residency or a skincare center. But when you make the diagnosis of cancer, you have to realize that it may not just be in the lower extremities. So you are going to refer to oncology. You need to look whether there's lymph node involvements. You need to look at other parts of the body. And that's a little bit beyond our scope of practice. But believe it or not, you could be the first podiatrist that identified this and really save a patient's life. That's really I think the message that we're really trying to achieve today.
Yes, I agree. Yeah, I think from a malpractice standpoint as well, when you refer out, you need to make sure that you assist the patient in going to that referral and not just assume it happened. Make some calls, follow up. Don't just say come back in 6 months and then they've never seen the oncologist.
That's more work that we don't get reimbursed for. So it's like I understand where we're at. So again, I just like to be a comprehensive podiatrist. I mean, really, we should be experts in the lower extremity, and that includes dermatology, neurology, musculoskeletal, all the systems. Why are we so laser focused on just bone and joint surgery? I don't have an answer for that.
Yeah, you have to go through the skin first. So we
Yeah,
need
no,
to.
I like that one. I
Yeah.
got to remember that one.
Yeah. So you mentioned the making it part of your routine skin exam, even if you're evaluating something else. Can you go through a little bit of how you do that? and how you
Well,
document that?
yeah, number one, it boils down to fundamentals. Doing a good history and physical. That goes without saying on every patient. Number two, paying attention to the entire lower extremity that's coming in your office. So even if someone comes in with a hammer toe or heel pain or a bunion or ingrowing toenail, you need to do a comprehensive lower extremity exam. You really need to look for things that could be wrong. You need to educate your patients that if you see, let's say, a small lesion on the back of their leg, to identify that and document that in the chart. I love digital photography. I think a photograph is worth 1,000 words. And certainly I think part of your record, now that's a two-way street too, because if you photograph and you document it and you don't treat it, then it turns out that could be a problem, but at least you're doing the right thing as being, a doctor going above and beyond. And really it's just having a high index of suspicion, knowing that, these conditions exist. These are not unusual. And the number one thing is that skin cancer is not painful. So patients aren't coming to your office complaining these lesions. They might not even believe that it's a problem. It's up to us to kind of educate these patients and really recommending taking a sample of skin, doing it sooner than later, and really not making a big deal about it. We're not doing a big surgery. You don't need to go to the hospital. A laminar flow room. You don't need a special room. Basically, this is something to be done in every treatment room, and it's a relatively fast and easy procedure, especially if you're doing a 2 or 3 millimeter punch. There's really no downside to doing that.
Yeah. And is your preference to do punch biopsies over shave?
Yes. I'm going to say now, and there's multiple reasons for that. Number one, punch biopsy goes through all three skin layers, the epidermis, dermis, and subcutaneous tissue. A shave biopsy, if you're doing it correctly, should only be in the epidermis. And there are a lot of conditions that you want to sample down through all three skin layers, where I think a punch biopsy offers significant advantages, for sampling all three skin layers. The reason dermatologists do a lot of shaves over, let's say, punches is because most of their lesions are on the face and head and neck, and they're worried about healing, and they're worrying about scarring, where basically a punch will have a little scar, where a shave, in theory, if it's done correctly, should not have a significant scar. That being said, another thing is the fact that I think for an average podiatrist, doing a punch biopsy is significantly easier than doing a shave biopsy. I mean, I've taught hundreds of biopsy workshops, and to do a shave biopsy really correctly, most podiatrists are very aggressive with it, and they tend to go down to the basal layer anyways. So they're kind of excising the whole lesion. They're not staying in the epidermis. So really, if I have to choose anything, it's probably going to be a 2 or 3 millimeter punch biopsy is going to really represent the majority of conditions. Will give you a wonderful sampling and diagnostic value from that. So if I have to choose one, that would be the one I would choose.
Yeah, I agree. The other thing I like the punch better for is it doesn't enlarge the lesion. I feel like shave biopsies make it bigger, and then if you have to do a wide excision, you're taking out even more tissue.
For sure, yeah.
So, well, what is one thing that you wish every podiatrist would do differently when examining their patients?
Number one thing is well, I'm not sure there's any one thing, okay, but let's put in a collection of things. I'm going to say, number one, have an index of suspicion, okay? Just don't assume skin cancer doesn't occur in the lower extremity. Number two is to, really look for lesions to biopsy. I mean, this is not an unusual thing to say, because basically what is crystal clear is that no physician, whether you're a dermatologist, whether you're a podiatrist, whether you're a plastic surgeon, no physician can 100% be correct with their designation of benign versus malignant lesions just by looking at it. It is crystal clear that the diagnosis for an unusual lesion, even something simple like a toenail, those are generally done with a histopathology, laboratory diagnosis, looking at a cellular level with special stainings, and it is done by a dermatopathologist, where if you literally are just looking at a lesion, you're never going to be 100% correct with your guess. And certainly if you're not going to be correct with your diagnosis, you're not going to be correct with your treatment. And the last thing you want to do is miss a malignancy. Even if it may not occur that often, you just don't want to be the doctor of record that missed the skin cancer, because that's super, super hard to defend when the evidence is so crystal clear that skin cancer is not painful. Skin cancer is very common. It occurs in the lower extremity. Here's all the warning signs, and the doctor missed it. And the fact is that really is a problem. So the gold standard for all dermatology issues in the lower extremity is going to be doing a biopsy or sending a sample to a laboratory, whether that's a skin cancer or what you think is a fungus toenail. We need to go beyond empirically treating patients based upon our subjective diagnosis with our visual skills. It's okay to start that way, but I think we've evolved as a medicine to employ diagnostic services. When a patient twists their ankle, do you say, "Oh, it looks like you sprained it. Here's a splint," or you say, "No, let's get it. Let's get an X-ray." A patient comes in with a hot red swollen first metatarsal phalangeal joint, painful to moving. Are you thinking like, "Well, it might be gout. I don't know. Try this medicine," or do you order a blood test? If a patient has an infected ulcer, do you say, "Well, I don't know, try this medicine," or are you going to take a culture and try to identify what that organism is? And the same criteria exists for dermatology for skin and nails, that we need to take this more seriously. We need to look at laboratory diagnostics. We need to consider sampling these specimens with either a punch biopsy or shave or curettage or even a clipping of nail, send it to a laboratory for staining, choose whatever lab you want, choose whatever test you want, and at least get some objective, granular, evidence-based medicine report showing what you think is subjectively, you're going to have a differential diagnosis. It's just going to help you be a better doctor, and it's going to help improve outcomes. And in theory, you may actually save somebody's life. And I think that's the goal here.
Want to receive a monthly newsletter with topics from the Insured Connection? Head over to picagroup.com/Insured Connection and join our email list to have it delivered right to your inbox.
Right. I don't think you're ever wrong in doing a biopsy if you've documented thoroughly all the things that it's funny looking, all the A, B, C, D, E, Fs, and that you're looking to save the patient's life.
Yeah, I mean, that's an interesting thing too when you talk about that. I mean, I don't think there's a whole lot of liability in terms of just doing a biopsy, where there's a tremendous amount of liability of not doing the biopsy. When you even look at, let's say, dermatology, okay, the dermatology benign to malignant ratio for biopsies is around 14 or 15 to 1, meaning they're going to do 14 or 15 biopsies and maybe one of those a malignancy. So that still means, that a lot of them are benign. But when you look at podiatry, there's a few podiatrists in the country that are 1-to-1. Okay. Wow. How do they do that? Are they better than dermatologists? No, it just means they only did one biopsy of the year and it just happened to be a malignancy. So the fact is that the average podiatrist, when I look at the data, it's probably a 4-to-1, maybe a 3-to-1. So in other words, what I'm seeing is that when podiatrists finally decide to do a biopsy, it's bad. Okay. So I think that is skewing the data and it's skewing the numbers. It doesn't mean we're better than dermatologists in terms of our benign to malignant ratio. There's just no way a podiatrist is going to be audited for doing too many biopsies when the average podiatrist probably only does 3 or 4 biopsies a year and the dermatologist does about 500 per year. So really, I just really would like to reinforce, to the profession to have a high index of suspicion. Don't just assume everything is benign. And if you are intellectually curious, or you want to know what this is, then take a sample and send it off to the lab. And that goes for skin cancer, nails, or anything in the skin and nail lower extremity. Be an expert, be a good doctor. You will have better outcomes. You'll save somebody's life, and you will actually have a more successfully practice from a financial standpoint. I think it's, in terms of your perspective, it's going to lower our malpractice risk also.
Great. Can you walk me through your protocol for when you get that report back or they call you directly and say, hey, there's a melanoma here? What is your order of telling the patient,
Well,
that?
that's never an easy conversation. And most labs may call you, okay? They're not just going to send the report in the mail. I mean, some do, okay? But I'm talking about, the main podiatry labs. And what happens is that, that's really kind of an opportunity for you to really, reality hits you like a brick wall. Like, oh my God, I really have to break this news to a patient that they have a cancer or specifically a malignancy. And now the number one concern the patient is going to say is, well, am I going to die from this? Okay. And I don't think we've really been trained in these conversations of how to have this with the patient because it's so unusual. But we're normally delivering good news, like, oh wow, our surgery was successful. We fixed that broken ankle. We took out that thorn or whatever you had, or we fixed the ingrowing nail. We're having serious discussions. But I think the really good news here is that if you catch it early, if it hasn't metastasized, and some of that you can find from the biopsy, in terms of the level of this, I think it's just reassuring to the patient to know that, look, skin cancer is very common. Okay. And number two, most people do not die from skin cancer if you catch it early. So the fact that we did a biopsy, the fact that it came back positive is certainly of concern, but it's really good news that we caught it. Get over the initial shock, like, oh my God, it's a melanoma. Then they're like, oh my God, I'm so thankful to this doctor for saving my life. So then it's going to be up to you to determine, how do you want to treat it? Do you want to be the physician that actually excises this and takes the proper margin? Are you competent to do a rotational flap? Or, do you want to refer this to dermatology or plastic surgery or oncology, and get the medical doctors involved? And really, you need to really be on the lookout whether it has gone to the lymph node level or other areas. And I think what happens is that you quickly realize that a podiatrist is now a valuable member of the medical community, but we're not necessarily the captain of the ship when it comes to the triaging for total skin cancer. We really, at that time, might need to step back a little bit in our role in terms of letting another medical specialty take the lead. But when it comes to the lower extremity, we're very competent in terms of treating whatever comes our way.
Yeah. And what systems can a clinical practice put in place to avoid missing a suspicious lesion or dropping it, losing a biopsy result or not following up on the result?
Well, the number one system is really just old school, being a good doctor, not being rushed, taking your time with the patient. Don't laser focus on the chief complaint they come in. Treat the patient not just an ingrowing nail walking in the door. It's a total person. It's looking at the entire lower extremity. If you do send out, let's say, biopsies. Maybe you have an intake outtake form in your lab. Your medical assistant could do that, where you're going to track these results, whether you do it with electronic medical records or however the laboratory is going to send those results to you. You should be alerted to these things. Now, again, if it's a benign lesion, then generally it's something you might see the next time you see the patient. But if it is a malignancy, all sorts of red flags should go off. In other words, you should take that serious, and then basically make sure that you call the patient directly saying, look, we need to see you as soon as possible. And then in terms of medical photography and documentation and dictating or documenting your electronic medical records, the discussions that you had about the seriousness of this and the appropriate actions you're going to treat. Now, maybe the podiatrist doesn't want to treat, or maybe the patient wants to go see a dermatologist instead of a podiatrist, and documenting all of those things. But don't just assume that the patient is going to follow up on that. That's part of our job too. And this, again, I'm not saying that we need to add more work to the average podiatrist, but these are life and death situations. These are serious, and this should really not fall through the cracks at all.
I also think it's important to train your staff that they're not the person who should be giving the patient results.
Right. And look, I get it. I mean, a lot of times patients get angry because they're like, well, why can't I just get the results? It's my pay, my results. I just want the report, because they're trying to, I don't know, let's say $20 copay to see you, or they just don't want to come see you. So I get that. Okay. Patients are like that. But we need to just explain the seriousness to these patients, and we're the physicians. And just say, look, it's an uncomfortable situation we're in. We're not doing this to try to get a $20 copay. This is something we have news to deliver that needs to be face to face, and we just can't send you the report because it's a very serious situation.
Yeah. And you want to be able to fully answer any questions, which your
Yes.
staff are not going to be able to answer.
Yes.
Yeah. All right. Well, we have a few minutes left. I'd like to wrap up with could you give us an example of a real case study that you had that sticks out in your mind that you really remember?
Probably say the most significant one that really I remember the most. It was probably the first few months when I was starting my private practice. Now, again, I'm maybe dating myself a little bit now. Okay, so I'm kind of going way back there. But basically, this is a situation where a patient came to me, and maybe I was in practice maybe 2 months or so, and came in with this huge, what I thought to be a plantar verruca on the tip of his hallux, that it was almost like the whole tip of the hallux was there. And, basically the problem was the patient come in saying, I have a wart on my foot. So I'm like, oh, okay, looks like a wart. Smells like a wart, act like a wart, we'll treat it like a wart. So, okay, let's start treating it with some topical medications, and it was not responding. So I'd probably say it took me maybe a month or so where I decided to kind of do a shave and send it off. I don't even think I did a punch biopsy back then. I just wanted to take some sample and send it off to the lab. And it basically came back squamous cell carcinoma. I almost fell out of my chair, okay, because I was trained in a surgical residency. I was wanting to just do, ankle fractures and trauma and ER all day long. So, the skin lesion comes in that I thought was what was a really what I thought was a plantar verruca really turned out to be a squamous cell carcinoma. So because I was so young in my career, I ended up referring it out to a dermatologist that I respected. And basically, that's happening every single day in podiatry, that these patients are coming to see us, and it's whether or not we are catching it or we're missing it. And if even patients, even doctors seeing patients in nursing homes, there is a lot of squamous cell carcinoma out there that's being missed. And really, that's not anything to be proud about. I think the average podiatrist is pretty skillful to identify the malignant melanoma. But when you look at basal cell carcinoma, squamous cell carcinoma, or amelanonic melanoma, we're missing a lot of those. So let's do better.
Agreed. Well, thank you for sharing. Thank you, Dr. Scherer, for joining me today. Your expertise and insights were greatly appreciated. I enjoyed for Bako Diagnostic to partner with PICA for this important topic in this special episode. Thank you to the listeners. Be sure to subscribe to your favorite platform so that you don't miss our upcoming episodes of the Insured Connection podcast.
And that's it for this week's episode. But let's continue connecting. If you're enjoying the Insured Connection, don't forget to leave a review on your streaming platform and subscribe now so you can connect with us each time we post a new episode. To stay connected with us throughout the week and to tell us topics we should discuss on future episodes, go to picagroup.com/insuredconnection.